Anesthesia Rounds, a series of discussions of problems confronting clinicians in the field of anesthesiology. In this discussion, Dr. Richard J. Kitts comments on factors that lie behind a rational choice of muscle relaxants. Dr. Kitts is Associate Professor of Anesthesiology at the College of Physicians and Surgeons, Columbia University in New York. He is also attending anesthesiologist at Presbyterian Hospital in New York. Dr. Kitts will discuss the physiology and pharmacology of muscle relaxants against the backdrop of such problems as the following: the normal physiology of the myoneural junction, also various types of muscle block. In addition, he will take up the clinical significance of anticholinesterase agents. And finally, he will discuss anticipated developments in the pharmacology of muscle relaxants. Anesthesia Rounds is presented as a service to clinicians in the field of anesthesiology by Ayerst Laboratories. Dr. Kitts, would you describe the microanatomy of the myoneural junction to provide a foundation for a discussion of its physiology and pharmacology?
Yes, and fortunately for us, the microanatomy of the myoneural junction is fairly well understood. The motor nerve terminus contains a number of small vesicles which are believed to contain acetylcholine, and separating the nerve terminus from the muscle part of the myoneural junction is the synaptic gap or cleft.
About how wide is this gap?
About 200 angstrom units across.
From where to where?
From the presynaptic membrane, which covers the nerve terminus, across the synaptic gap to the postsynaptic membrane, which covers the myo portion of the myoneural junction. These are the three essential elements of the myoneural junction as we understand it. What is important to emphasize is that there is no protoplasmic continuity between the nerve terminus and the muscle itself. Other features central to an understanding of the junction's functioning are the existence of a reservoir of acetylcholine in the nerve terminus.
In the vesicles?
In the vesicles, yes. And the fact that the postsynaptic membrane is a series of folds, it's actually fluted, and thus presents a much larger surface area than exists on the nerve terminus portion. It is for this latter reason, it is thought, that the junction operates as an electrochemical amplifier of nerve impulses. Of significance also is the fact that there is a specialized portion of the postsynaptic membrane, the cholinergic receptor, with which acetylcholine reacts to perform its essential function, the depolarization of the postsynaptic membrane, and thereby propagating the nerve impulse.
It would be of interest to know, Dr. Kitts, whether the cholinergic receptor, the receptor site on the postsynaptic membrane, has been physically identified, or is this a postulated site?
Well, that's a subject of great current scientific interest. Its existence has been declared by physiologists, at any rate, to be virtually self-evident, but in fact, it has never been isolated nor chemically characterized. That is to say, we do not have it in our test tubes as an entity to examine. We do not know what it is, whether it is a protein, a fat, or a carbohydrate. It is still in the realm of concept, although it's a rather well-founded concept.
Well, then, is it correct to say that the site may be either an anatomical landmark, so to speak, or a molecular entity with a locus on the postsynaptic side, the unit not necessarily being in a given place at all times? In other words, that it is either a chemical element or a physicochemical element, but has not been characterized beyond the fact that there seems to be a need for such a site.
Yes, I think that puts it rather well. The present concept demands the existence of something with which acetylcholine can chemically react to propagate the nerve impulse. But the nature of this cholinergic receptor with which acetylcholine reacts is not known.
Are there other elements on the presynaptic side that are significant to an understanding of the function of this specialized synapse, the myoneural junction?
The most important elements in the presynaptic area, in the nerve terminus itself, are the vesicles. These small containers of acetylcholine have been important to our understanding of events in this area. There are a great number of these presynaptic vesicles, many more than are required for a specific impulse to be propagated, a fact suggesting that acetylcholine is stored in the vesicles. This assumption is supported by knowledge that the rate-determining enzyme, choline acetylase, responsible for synthesizing this ester, acetylcholine, operates only slowly.
What quantitative demands are made on acetylcholine, Dr. Kitts?
We know that 100 impulses or more a minute may pass a given synapse. If each impulse requires 1 million molecules of acetylcholine, then 100 million molecules of acetylcholine per minute will be required to take care of the traffic. Now, it's impossible for the choline acetylase system, responsible for the synthesis of acetylcholine, to create, on a demand basis, sufficient acetylcholine to meet the needs for rapid synaptic activity. Thus, a reservoir of acetylcholine must be created, and the reservoir consists, in the aggregate, of the synaptic vesicles, in the so-called vesicle reservoir concept of acetylcholine storage.
Then the vesicles are both the functioning unit and, because of their number, a storage depot for acetylcholine.
Yes, although this is not fully established. We do know that each vesicle contains somewhere between 4,000 and 40,000 molecules of acetylcholine. The enzymes responsible for the synthesis of acetylcholine also seem to be associated with the vesicles. I'm thinking particularly of the enzyme choline acetylase, which is the principal enzyme in the synthetic pathway. Some evidence supports the idea that it's stored within the presynaptic vesicles, although this has not been definitely established for the myoneural junction itself.
Have storage depots been located elsewhere at the junction?
No, that is not to say that acetylcholine cannot be found elsewhere, but the presynaptic vesicles seem to be the storage sites at the myoneural junction.
Dr. Kitts, would you describe the characteristics of acetylcholine function with respect to the transmission of nerve impulses across the myoneural gap?
Well, this is essentially the physiology of normal synaptic transmission. As we understand it today, a nerve impulse, which is a wave of depolarization, proceeds along a nerve to its terminus, and at this point, in some unknown way, causes the rupture of 20 to 25 or more synaptic vesicles that lie adjacent to the synaptic gap. These vesicles literally spew their contents into the synaptic cleft, and some of the molecules of acetylcholine now diffuse across the 200 or so angstroy units to the other side, which, of course, is the postsynaptic membrane. Here they react with a postulated specialized entity, the cholinergic receptor.
What events follow the combination of acetylcholine with its postsynaptic receptor?
An increased exchange of sodium and potassium across the postsynaptic membrane initiates a fall in its resting potential. The potential rapidly reaches the critical threshold for a self-propagated action potential.
Dr. Kitts, is there at present any understanding of the mechanism that relates the combination of acetylcholine and receptor with the increased permeability of the postsynaptic membrane to sodium and potassium? Has this mechanism been explained?
Well, the evidence is relatively direct. When acetylcholine combines with a postsynaptic membrane, one can actually measure the exchange of sodium and potassium. Potassium leaves its intracellular location, where it is in relatively high concentration, and sodium enters the cell. We do know, therefore, that the postsynaptic membrane at this time becomes permeable to ions of sodium and potassium.
But the mechanism that operates to increase postsynaptic membrane permeability is not understood?
That's correct. We don't know exactly what takes place. However, there are some reasonably good guesses. The one which is currently in vogue postulates that the cholinergic receptor is a protein, and proteins, as we know, can undergo changes in shape. In the combination of cholinergic receptor protein with acetylcholine, the receptor's shape may be altered so that gaps or pores now appear in the postsynaptic membrane. Sodium and potassium may pass through these pores.
So the initial change in permeability, according to this theory, would occur at the site of the cholinergic receptor or contiguous to it.
Yes, contiguous to it is the best way of saying it. However, that does not mean that similar permeability changes could not be propagated from area to adjacent area, which then influences the next adjacent area, and in this way, spreading permeability changes throughout the entire region.
And that would delineate the concept of the spread of the action potential.
That's right.
Dr. Kitts, is anything known about the detailed mechanisms that cause the spilling of acetylcholine into the synaptic gap, beyond the fact that an impulse comes down to the terminal filaments of the nerve?
No, we do not know the intimate mechanism whereby the impulse causes the rupture of the synaptic vesicles.
At what level of postsynaptic membrane potential is the action potential initiated?
Well, if an electrode were to be placed in the synaptic gap and another within the muscle itself, a potential difference across the postsynaptic membrane could then be recorded. And this is done all the time, of course, and the value of a negative 90 millivolts is measured. This is the so-called resting membrane potential.
Is that a fairly steady value, or is there a range of values found at various points in the body?
No, it's a rather standard value measured at myoneural junctions. It may vary from a negative 85 to negative 95 millivolts, depending on certain circumstances, but the value is within this range. When acetylcholine, then, reacts with the postsynaptic membrane, a fall can be recorded in this resting membrane potential. That is to say, its value begins to approach zero.
Does it reach zero?
Yes, and it goes beyond zero. It overshoots, as a matter of fact.
To a positive potential?
To a positive potential. Now, in a more detailed way, the falling membrane potential will return to a negative 90 millivolts, that is resting potential, unless it reaches a value of about a negative 40 or 45 millivolts. At that time, it is irretrievable. You cannot call it back again. The machinery has been set in motion by the exchange of sodium and potassium. This is the self-propagated action potential itself. From about a negative 45 millivolts, the action potential will fall to zero and will actually overshoot to a positive value of maybe 10 to 20 millivolts before it repolarizes.
So the values critical to the action potential, the threshold values, are in the neighborhood of minus 40 to 45 millivolts.
That's correct.
Dr. Kitts, what mechanism seems to be concerned with return of the postsynaptic membrane potential to the resting level?
In repolarization, when the resting membrane potential of a negative 90 millivolts has been reestablished, potassium has been returned to its intracellular location, and the sodium has been literally pumped back out of the cell to its extracellular location. The sodium-potassium relationships obtaining before depolarization have been reestablished.
What is the significance of the role of acetylcholinesterase in the normal physiologic activities at the junction?
I think the role might be described in one word: central. Without the enzyme acetylcholinesterase, the normal physiology we've described breaks down, because this enzyme is responsible for destroying acetylcholine. If acetylcholine were not destroyed, it would maintain the postsynaptic membrane in a relatively refractory state, so that a following impulse would have no effect.
This means the membrane would remain in the depolarized state?
It would prevent the reestablishment of a resting membrane potential, a negative 90 millivolts. Therefore, if we are to be ready for another impulse following close behind the initial one, we must very quickly get rid of acetylcholine once it has done its job, achieved depolarization. And the element responsible for destroying acetylcholine, remember, is that essential enzyme, acetylcholinesterase.
Dr. Kitts, where is this enzyme stored in relation to the junction?
Well, if the myoneural junction were stained for the presence of acetylcholinesterase, it would be found at the nerve terminus as well as within the postsynaptic membrane. It seems to be most concentrated on shoulders of the indentations, the fingers that constitute the synaptic gutter in the postsynaptic membrane. Of course, that is an important location because it is where acetylcholine performs its function. The ester can therefore be hydrolyzed immediately after it has depolarized the postsynaptic membrane.
What other mechanisms might be involved in the destruction of acetylcholine?
Its action at the myoneural junction can be limited by diffusion. It can simply diffuse away from the gap where it is in high concentration. Secondly, acetylcholine hydrolyzes spontaneously in an alkaline medium, and, with the pH of the body being 7.4, a certain amount of alkaline hydrolysis occurs. But by far the most important element in terminating acetylcholine activity at the myoneural junction is the enzyme acetylcholinesterase. Appreciate that the activity of a single synaptic event is measured in milliseconds. And if you're going to affect activity that takes place in a millisecond time frame, you need something that works in the microsecond range. And that's what acetylcholinesterase does.
Well, how rapidly does acetylcholinesterase work?
One molecule of the enzyme acetylcholinesterase can take on around 800,000 molecules of acetylcholine per minute and destroy them all. It has a very, very fast turnover time, as we say.
Well, now, Dr. Kitts, what general principles apply to the function of muscle relaxants? How do they interdict neural transmission across the synaptic gap?
The classic theory by which we explain the function of muscle relaxants is the following. These drugs are apparently bound to the cholinergic receptor, that specialized element of the postsynaptic membrane with which acetylcholine binds to achieve depolarization. Now, we interfere with the integrity of that mechanism by permitting a foreign molecule to compete for the receptor, to preempt the place of acetylcholine.
What distinguishes one group of muscle relaxants from another?
Foreign molecules that can be bound to the cholinergic receptor are generally thought to be of two types, the receptor activators and the receptor inhibitors. We call the receptor activators depolarizing muscle relaxants, for example, succinylcholine and decamethonium. The receptor inhibitors are non-depolarizing muscle relaxants, such as curare and galamine.
And the main difference is in relation to the effect on acetylcholine?
The depolarizing type, the receptor activator, mimics the action of acetylcholine but maintains the postsynaptic membrane in a depolarized state for a relatively long period of time.
Dr. Kitts, how would the action of a larger than physiologic dosage of acetylcholine differ at the cholinergic receptor from the action of a high dosage of depolarizing muscle relaxant?
That's a good point. A very large dose of acetylcholine would produce a rather long depolarizing block similar to that produced by succinylcholine. That's understandable because succinylcholine, of course, simply consists of two molecules of acetylcholine bound together. The major difference between the two is that acetylcholine is broken down in microseconds by acetylcholinesterase, and succinylcholine is broken down much more slowly by a different enzyme, plasmacholinesterase or pseudocholinesterase.
Is the action of depolarizing agents in general of a short duration?
No. Decamethonium, for instance, acts for something like 20 to 40 minutes, depending on the dose. With succinylcholine at the single dose levels we usually give, activity normally persists for somewhere between 2 and 6 minutes. So some depolarizing muscle relaxants have durations of action that are short-lived, and others are long-lived.
Is the activity time of depolarizing agents related to whether the appropriate enzymes are present?
That is correct. Plasmacholinesterase determines the duration of effect of succinylcholine. If this particular enzyme is absent, as it is in rare cases, or is in deficient quantity, as it may be in patients with severe hepatic disease, or if an atypical form of plasmacholinesterase has been created through some genetic variation, then succinylcholine is not broken down as rapidly as it would normally be. And then one sees the many problems associated with a patient who is apneic for a long period.
Now, what should be said about the mode of action of the non-depolarizing drugs?
These, in general, are longer acting. They are not hydrolyzed at all by enzymes. Galamine, for instance, is excreted virtually intact by the kidney. The principal point to be made for the non-depolarizing curare-like drugs is simply that they have a relatively long action when compared with succinylcholine.
Then the mode of action of the non-depolarizers is one of competitive inhibition at the receptor?
Yes, it does not depolarize the postsynaptic membrane. Rather, it blocks depolarization of the membrane. It prevents acetylcholine from carrying out its function.
Dr. Kitts, is there something about the quality of the neuromuscular block that distinguishes the curariform from the depolarizing agents?
Actually, this is a matter of concentration. In the usual clinical concentrations, succinylcholine produces a rather quick, profound block of short duration. Curare, that is D-tubocurarine, can produce a block of equally quick onset and profoundness, but of a much longer duration. However, we rarely use a very high concentration of curare that are needed to achieve such a profound block.
How may one characterize the so-called desensitization or phase 2 muscle block?
Phase 2 block, the desensitization block is a better term, I think, is peculiar to the depolarizing muscle relaxants. Some characteristics of the postsynaptic membranes change from those of a depolarizing to those of a non-depolarizing block. These changes, in fact, define the block. We think desensitization block is the preferable term, by the way, because the membrane's resting potential has been partially restored, but it cannot be excited by acetylcholine. It is, in essence, desensitized.
Do we know what is happening at the postsynaptic membrane that explains why, with a normal resting potential, there is no excitability?
No, it is not well understood. It is known that sodium and potassium ion conductance is interfered with in some manner. If a change in the conformation of the receptor protein is essential to conductance, then possibly this alteration is prevented from occurring.
How may the several muscle blocks be clinically distinguished, Dr. Kitts?
Clinically, it is very difficult to distinguish between the non-depolarizing and the desensitization types of block. The true curare block, however, can be distinguished from the depolarizing block with the aid of nerve stimulators, such as those described by Dr. Ronald Katz of Columbia University and Dr. Harry Churchill Davidson of St. Thomas Hospital, London.
Is the nerve stimulator in general use for monitoring the effects of muscle relaxants and distinguishing depolarization from curare blocks?
Yes, it's in frequent use. It's a good unit, I think, because it does several things for you. It allows the anesthesiologist to monitor the state of relaxation during the course of the operation. And postoperatively, it tells him whether there is any persistent relaxation. It suggests whether there is need to antagonize a residual block. Without the nerve stimulator, these factors are much more difficult to determine precisely.
And now, with respect to an overly persistent block, Dr. Kitts, is the use of the anticholinesterase agents significant in distinguishing the type of block?
Yes. The curare, the non-depolarizing type of block, can be antagonized by anticholinesterase agents such as neostigmine or edrophonium. They function by different mechanisms to paralyze the essential enzyme acetylcholinesterase. Thus, acetylcholine accumulates, and, invoking the law of mass action, it will literally displace curare from the cholinergic receptor.
If one were not certain of the type of block that existed, he would have to be rather careful, would he not, in how he determined this with the use of anticholinesterase drugs?
Oh, yes. Fortunately, though, the nerve stimulator can help distinguish between depolarizing and non-depolarizing block before anticholinesterase agents are used.
Dr. Kitts, would you characterize the results of nerve stimulation in myoneural blocks?
Well, the curare block will show fade when one switches the dial to twitch. Over several minutes, it will be noticed that muscle contraction diminishes. Switching the dial to tetanus, it will be seen that the muscle contracts, but that contraction is not sustained. Switching back from tetanus to twitch induces post-tetanic facilitation, an accentuated response to a single twitch, and then this too gradually begins to fade.
So that there is non-sustained tetanus, post-tetanic facilitation, and fade.
That is correct, with a non-depolarizing block. And the fourth element here is the fact that this type of block can be antagonized with anticholinesterase agents. None of these four elements that we have talked about characterizes the depolarizing block, so that it's all of one kind and none of the other. One does not see post-tetanic facilitation, does not see fade, and the anticholinesterase agents will not antagonize the depolarizing type of block. They will, in fact, intensify it.
But there is no clinical way to distinguish desensitization from non-depolarization block?
Only by knowing the course of events. If, following rather large doses of depolarizing drugs, a block evolves that has the nerve stimulator characteristics of a curare-type block, then a desensitization block is present. The phase 2 block of old was thought to be antagonized by anticholinesterase agents, and indeed there does seem to be a certain amount of return of muscle function. However, one can still note that function never returns to normal, that the block is only poorly antagonized.
Dr. Kitts, we know that one indication of an overly prolonged block is a depression of respiratory function. Are there other ways in which this can become clinically manifest at the end of an operative procedure?
Yes, there's also clinical evidence for the persistence of myoneural blockade. And you mentioned what is probably the most important factor, failure to maintain adequate pulmonary ventilation. This can be determined, of course, by measuring alveolar ventilation as a function of minute volume, or blood gas values can actually be measured. Also, if the patient cannot stick out his tongue and maintain it in an extended position for 30 seconds or so, that would also tend to indicate that muscle relaxants were still functioning. In addition, the patient's ability to lift his head off of a pillow is another good index for persistence of muscle relaxation. And third, there is simply the matter of opening the eyes. It seems that the eye muscles are among those that are most exquisitely sensitive to muscle relaxants. If the patient responds by shaking his head, but still cannot open his eyes, then the persistence of relaxation is strongly indicated.
Are there instruments, equipment, materials that should be available at all times when muscle relaxants are being used?
Oh, yes. For example, there must always be a ready means of ventilating the patient when muscle relaxants are employed. In addition, the anticholinesterase agents and atropine should be at hand.
You said earlier, Dr. Kitts, that nerve stimulators should be standard equipment in this environment.
Yes, to follow the magnitude and duration of relaxation. An important point to make, I think, is that not everyone reacts in the same way to these relaxants. The monitor allows the anesthesiologist to evaluate properly this individual variation.
The monitor you refer to is the nerve stimulator.
Yes.
Dr. Kitts, what are the broad effects of the volatile or general anesthetics on the integrity of the myoneural junction? Are there general rules to bear in mind?
Well, there are several points we can make. The general inhalation agents do not seem to have a clinically significant action at the myoneural junction. Given in sufficient but clinically unlikely concentrations, several of our general inhalants can produce profound relaxation. Apparently, however, this is due to action in the central nervous system. With certain inhalation agents, particularly diethyl ether, the amount of certain muscle relaxants may be diminished significantly to approximately one-third what would otherwise be used in a given patient. The combination of ether and such agents as curare or galamine seems to be at least additive with respect to muscle relaxation.
What might be said about the generally recognized side effects of neuromuscular blockade? Muscular pain, increased ocular pressure, arrhythmias?
Increase in intraocular tension, muscle pains, and arrhythmias are all characteristic of the depolarizing type of muscle relaxant. We do not see them when we use curare and curare-like agents. They seem to be peculiar to the depolarization process itself.
Dr. Kitts, are these effects related to dosage size or to individual patients?
We don't know, for instance, with respect to muscle pain, exactly what causes the effect, but it does seem to be related more to the patient than to any specific dose. It seems to us that a modest dose of thiopental immediately before the use of succinylcholine attenuates the muscle pain associated with depolarization. With respect to the arrhythmias, rather profound bradycardias can be seen in children. Of course, the treatment here is prophylaxis with atropine in a reasonable dosage.
By way of summary, Dr. Kitts, what might we say about anticipated developments in the field of muscle relaxants?
Clearly, what is needed is a short-acting curare-like agent. Succinylcholine, as we have pointed out, although it produces a rather profound block of short duration, has a number of significant side effects. Curare drugs, on the other hand, do not have these side effects, but have relatively long action spans and require antagonists for their effects to be reversed. A desirable drug would have a short duration of action, but would produce a non-depolarizing block like that of curare. I think such an agent would be a major advance in anesthesiology, and I look forward to its creation. Much active research is going on in this area. In fact, we're actively engaged in it right here at Columbia.
Are there indications that these activities may be fruitful in the near future?
We hope so. I think that within the next 2 or 3 years or so, we'll have a series of drugs related to curare, that is to say, producing a non-depolarizing block, but having durations of action varying from the very short to the long. The anesthesiologist will be able to select a drug that lasts for 10 minutes, 20 minutes, half an hour, or what have you. One other significant advance that would be most helpful to anesthesiologists, I think, would be the isolation and characterization of this so-called cholinergic receptor. Once we understand its chemistry, its makeup, then we can literally tailor drugs to react even more specifically with it. If it could be shown, for instance, that the cholinergic receptor of the muscles of respiration were different from the receptor of the abdominal muscles, then we could design a series of drugs that would bind to the receptor of the abdominal muscles and bypass a mechanism of apnea when we want to achieve muscular relaxation.
Thank you very much, Dr. Kitts, for a most useful discussion. You have been listening to Anesthesia Rounds, presented as a service to clinicians in the field of anesthesiology by Ayerst Laboratories.